The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with another edition of The Genuine Article, and I've got a very interesting paper to discuss today. I'm talking with Dr. Robert Epstein, and Dr. Epstein is the Chief Medical Officer of Medco, and he's presented and now has in press in JACC a fascinating paper about the value of genotyping patients who are going to undergo warfarin therapy. Why don't you tell us what you found in this study?
Yes, our study was designed to look at whether or not genotyping would reduce hospitalizations for patients newly starting warfarin. And what we found was about a 30% reduction in hospitalizations among those who were genotyped versus a comparison group who were not genotyped.
Okay, and the two genes you particularly looked at involved the cytochrome P450 system and the VCOR system, as I recall.
Yes, that's right. These two genes have been shown in numerous papers in the last 5 to 10 years to predict maintenance dose pretty well. In fact, they explain about 33% of the variation in dose. What hasn't been shown is whether or not using the technology actually reduces adverse outcomes.
And the fact that you showed a change in outcomes was really impressive. And of course, the implication would be that it would be worthwhile for us to genotype every patient who was going to embark on warfarin therapy. But before we would do that, we'd look at the study, and one of the important aspects that's been brought up is that your study wasn't randomized, that it didn't have a randomized control, you used a historical control.
Yes, that's right. In fact, we did that on purpose. There had already been 3 prior randomized trials prior to our study, though they were very small, and there were about 6 already underway today. But in every case, they were looking at patients with a lot of inclusion-exclusion criteria, and the usual care arm wasn't really usual care. It was very strict kind of protocols of care with frequent INR measurements and whatnot. And what we were trying to look at was in unselected patients in typical practice settings, could genotyping be complementary to the usual care of patients that occur across America today?
Yeah, isn't it possible, though, that once physicians knew that they were being watched in terms of the results of their warfarin therapy, that they might be much more cognizant and much more careful with it?
Well, there's always a concern in every clinical trial or study or observational study where a physician knows they're being watched. But in our case, there was only one telephonic communication with the physician to see if they would order the test. They received the lab test, and that was it. There was no further follow-up. They weren't being reimbursed. There were no case report forms, and they weren't investigators like you'd see in a typical controlled clinical trial setting. So we really kept the intervention to a bare minimum and didn't feel like they really had much observation other than the initial contact.
Yeah, now one of the issues that was brought up, I believe it took 32 days to get the information about genotyping back to the physicians. Now, one would have guessed that they would have hit upon the optimal dose of warfarin by that time.
Well, I think in different settings that may be true. There was a recent abstract at another heart meeting just in May in which they found across 250 centers in America, the average time for reaching a stable dose was 17.9 weeks. So I think it really depends upon the setting. If you're in a very well, tightly controlled anticoagulation clinic or maybe an academic medical center, that may be true. But in routine practice in the sort of national scene in America, which is about 80% of the time, that may not be true that people get to a stable dose that quickly.
And I guess the last question that I heard frequently related to the new antithrombin drugs that are out there, dabigatran, I guess, being the most prominent. Will their availability make warfarin genotyping and the use of warfarin, in fact, moot?
Well, I think these new agents show a lot of promise. In the head-to-head trials against warfarin, they appear to have similar bleeding rates but lower thromboembolic rates. Of course, in our study, the use of genotyping lowered the thromboembolic rates. So I think we're still going to be left with the question, how well do these new agents perform against genotyped warfarin patients? And we don't know the answer to that from the current trials that have either been conducted or are underway.
Well, it's certainly a fascinating study. It's real world, it's a large group of patients, and it's outcome based rather than INR based. Very provocative findings, but very important, I think, to all of us physicians that use warfarin. Congratulations and thanks very much for being with us. For the Genuine Article, I'm Tony DeMaria.
The Genuine Article. Discussion and commentary based on articles from JACC.